Hello and welcome. I'm Bob Cusack, Editor-in-Chief of The Hill. Thank you for joining us for Diabetes Technology, Disparities, Access, and Equity. We will be exploring how disparities in diabetes caregiving and technology access impact vulnerable communities amid evolving population demographics. Before we begin, I'd like to thank our sponsor, the Diabetes Leadership Council, for its support of today's event. I'd also like to take a moment to thank my colleague, Julia Manchester, for joining me today to facilitate these important discussions. Improvements in personal diabetes management continue to enhance the quality of life for millions of Americans. However, innovations in technologies like insulin pumps and continuous glucose monitors are not equitably accessible. With some studies suggesting the diabetes technology disparity gap has widened for American children in recent years, how is the medical community making these essential tools available for everyone? How can leaders in Congress and the administration prioritize equitable advancements in care? And how can bias be eliminated throughout the healthcare ecosystem? We are going to be putting these questions and more in front of our fantastic speakers. But first, a few housekeeping notes. You can tweet us at the Hill Events using the hashtag #TheHillDiabetes. We are broadcasting live and we'll be taking your questions throughout the program. As with any live stream, you could experience occasional trouble with the video. Refreshing the page should, in most cases, fix the problem. My first guest is Chiquita Brooks-LaSure, Administrator for the Centers for Medicare and Medicaid Services. She oversees not only Medicare and Medicaid, but also the Children's Health Insurance Program and the Health Insurance Marketplace. Welcome, Administrator Brooks-LaSure.
Thank you. It's great to be with you today.
I'm dating myself, but I actually started my career in Washington covering HCFA, which was CMS, was called the Healthcare Financing Administration. CMS is a much better name. Let's start off with what CMS is doing. I know you have a Medicare diabetes prevention program. Can you tell us a little bit about that?
Certainly. And I first want to start with just talking about how much diabetes is such a critical an area of focus for CMS. We recently outlined our 6 pillars, and our first pillar is focused on health equity. And when I talk about health equity across the agency, I really think about us embedding it in every part of what I call the 3 M's: Medicare, Medicaid, and CHIP, and marketplace coverage. And when we look at diabetes, it is a condition that disproportionately affects communities of color and is one of the most one of the top costly illnesses for us as a country. So it's so important that we tackle this issue, and I'm so pleased that you are having a conference on this topic. So you asked specifically about the Medicare Diabetes Prevention Program. That is a program that is a demonstration that CMS has been running, that a lot of the people who participate in are very pleased with the efforts. And so one of the things that we announced this week is that we are trying to improve the model to increase access to services for people with Medicare in rural areas, and really try to decrease the number of individuals with diabetes in both rural and urban communities. One of our areas of focus here are really the ability to make sure that people living with diabetes are able to pay for their medications, creating programs that teach people living with diabetes about their treatment options, how the healthcare system works, and the value of adhering to their treatment protocols and everything that comes along with managing a chronic illness, and ensuring access to care through multiple channels. So one of our areas of focus at CMS is making sure that we're getting everyone who's eligible for coverage enrolled, and making sure they have access to the care they need when they are enrolled in coverage. And finally, I would say our approach is really trying to develop programs that people trust, so that they want to make sure that they're adhering to the things they need to do to manage their disease.
We've been taking questions, as I mentioned earlier, and I do have a question for you from our audience. It's from Julia Kenny, and she's a senior associate at the Diatribe Foundation in San Francisco. Her question is, how can we increase access to continuous glucose monitors for people with diabetes on Medicaid?
Such an important question. I think that our Medicaid program is vital. We have 80 million people enrolled in Medicaid and CHIP right now, and because of the efforts of so many states, and many of the people with diabetes are covered through those programs. As you know, Medicaid is jointly run by both us and states, and so a big part of the need to continue to make sure people have access to care is really working with states to make sure that they are covering the products and the treatments that people need. And also letting us know at CMS when there are access issues. So one of the things that we are thinking about as an agency is how we should and can strengthen the Medicaid requirements to access at the federal level, to make sure all Medicaid beneficiaries, enrollees are getting access to care.
From a big picture, why are the disparities so persistent in technology access? And what can policymakers do, whether that's you and Congress, to really help that situation?
Well, I would say that, as we know, there are disparities in our healthcare system, and that is something this administration is really focused on tackling head on. There are a variety of issues around why we have access issues, and particularly about technology. There continue to always be the back and forth about when is technology appropriate, and how do we cover the products that are so crucial for people to get access to care, at the same time manage fiscal pressures and constraints and realities. And so I think that one of the things we're continuing to do at CMS is trying to make sure that our programs are covering the innovative products that work, that really make it easier for people to have access to care. Of course, there are times when we need Congress to give us more authority, and we have limitations. And so that's, of course, when stakeholders go to Congress and ask or require CMS to take additional steps. But I think some of our larger issues, again, of making sure people have access and knowledge about what they have access to. So sometimes it's a question of things being covered but does everyone have access to the mechanisms that make sure your benefits are covered in the way that that the law intends?
You mentioned the Biden administration, which you were serving under. COVID-19, obviously a major focus of this administration. COVID-19 is deadlier with people with diabetes. Can you talk a little bit about that and the urgency of coming up with solutions and education, as you mentioned?
We have seen, as you said, that people with chronic conditions such as diabetes are much more likely to have poor outcomes because of the pandemic. I think one of the most important things that people can do is get vaccinated. We are, as you probably know, today announcing our requirement that healthcare facilities that are certified by Medicare and Medicaid make sure that their workers, their staff are vaccinated. And I think that's one of our key priorities in terms of getting out of the pandemic. I would say that we have learned, hopefully, as a society and certainly as policymakers, so many lessons during COVID-19 that we need to take into our healthcare system moving forward. So people with underlying conditions have worse outcomes, and that's because we need to make sure that we're getting people preventive services, that we are managing these conditions, and making sure that we are addressing not just what we think of as the acute need, going to the hospital, the asthma attack, whatever, the diabetes when it progresses to such a unfortunate place where we're leading to amputation and other worse outcomes. We need to make sure that we are getting and managing these chronic conditions upstream so that we don't get to these more serious complications.
Now, you've recently wrapped up your first 100 days as the CMS administrator, and for our viewers who may not be familiar with CMS, it is a big government agency, deals a huge payer, billions of dollars, hundreds of billions of dollars over the years, of paying to providers, dealing with Congress, making coverage decisions. How's the first 100 days gone? It must be a pretty intense job.
It is, but it is the privilege of a lifetime. I just am so thrilled to be in this role, especially at such a critical moment when we have such an opportunity to really change how our healthcare is being delivered. I truly believe that. I was a part of the passage of the Affordable Care Act, and that was born out of people really suffering because of the Great Recession and medical bankruptcies. And I think we saw how important it was for people with pre-existing conditions to no longer be restricted from getting health insurance. And I think we're in a similar moment where there is such a focus on addressing our disparities in our systems. We have more ability than ever to move the healthcare system in a better way. And so there's no greater place to be than in over an agency that has responsible for these 144 million lives. And we need to make sure that we are operating in a way that delivers care better for the American people.
It is definitely one of the most important jobs in the federal government, especially in healthcare. Thank you so much, Administrator, for joining us today.
Thank you. Have a good rest of your conference.
And now for a message from our sponsor, the Diabetes Leadership Council. I'd like to introduce Edward Hawthorne, Vice Chair of the Board at Diabetes Leadership Council.
Thank you, Bob. I'm Ed Hawthorne, Vice Chair of the Diabetes Leadership Council. The Diabetes Leadership Council unites former leaders of national diabetes organizations to drive policy solutions that improve the lives of people impacted by diabetes. Our leaders come from different states, backgrounds, and professions, but we are all united in our passion for advocacy and our shared commitment to breaking down barriers to effective and affordable and equitable healthcare solutions. I invite you to learn more about the Diabetes Leadership Council after today's webcast by visiting our website at diabetesleadership.org. I'm joined today by another passionate diabetes advocate and longtime friend of the Diabetes Leadership Council, Dr. Jasmine Gonzalvo. Dr. Gonzalvo is Director of the Center for Health Equity and Innovation at Purdue University, a clinical professor of pharmacy practice, and a clinical pharmacy specialist. She is immediate past chair of the Certification Board for Diabetes Care and Education and a current appointee of the National Clinical Care Commission, which is charged with evaluating and making recommendations to Congress and the Secretary of Health and Human Services regarding federal diabetes programs. Welcome, Dr. Gonzalo, and thank you for joining us today.
Thank you for inviting me, Ed. I'm really happy to be here.
Great. Well, today's focus is on diabetes technology, disparities, access, and equity. And we're covering a lot of ground on an important and complex topic. But there are three things we really want the audience to take away from today's conversation. An understanding and appreciation of technologies like continuous glucose monitors and insulin pumps that can positively impact a person's health and prevent or delay some of the costly long-term complications of diabetes. Recognize the importance of sustained, affordable, and individualized access to diabetes technology based on the person's unique needs and circumstances. And open the nation's eyes to the diabetes disparities and inequities that Black, Indigenous, and other people of color are experiencing in the US, so we can come together constructively to drive meaningful solutions. Now, there are policy challenges that need to be addressed, but also some provider, family, and community level actions that could help to close the gaps in access and health outcomes. So can you tell us about the Center for Health Equity and Innovation and the interdisciplinary approach that you and your students take to address health disparities in urban and rural communities?
Absolutely, Ed. That's a fantastic question. And I really like talking about the Center for Health Equity and Innovation. And I would say that the biggest interdisciplinary approach that does center around innovation is the collaboration with community health workers. And community health workers are really those people who come from the communities who with the biggest disparities, and they have lived experience. And so one example that the center has really is helping in a clinic which serves people experiencing homelessness. And we're partnering with CHWs who have lived experience from those communities with some of the struggles, including mental health disorders or substance abuse issues, and having those people connect with the clientele served by the clinic in order to address those barriers in ways that healthcare providers traditionally have struggled. And so working with community health workers to really address the health disparities and improve and optimize outcomes is what the center is currently focusing a lot of effort on, as well as the other piece with the social determinants of health and upstream factors. For example, working with high school students on a strategic plan for well-being, both including physical and mental, nutritional aspects of a high school student's lived experience. So those areas, Ed, I think are where we're spending a lot of our time through the center very early on in our efforts and through the pandemic is the social determinants of health and working with community health workers.
Now, the center is housed at Purdue School of Pharmacy, correct?
Yes, that's correct.
So how do community pharmacies fit within the neighborhood context when it comes to addressing diabetes and other health factors in these underserved communities?
That's a fantastic question, Ed. And a couple of initiatives that we've had really early on with the Center for Health Equity and Innovation is one, we have partnered with Walgreens to offer flu and COVID vaccinations in partnership with local food banks. And so what we really do with this partnership is bring the vaccines to the communities who need it the most. We're serving about 400 to 500 families per event, and we're able to address the vaccine hesitancy within these populations as well. And so we really bring that trusted rapport that we have with the Walgreens pharmacists and technicians and their staff, and we bring it to these communities to really overcome those barriers of mistrust and hopefully improve access to, in this case, vaccinations for these food insecure populations.
Well, I tell you, it sounds like the collaboration, partnership, and trust are huge proof points for you. So
absolutely.
The COVID-19 pandemic has certainly shed much needed light on health disparities in underserved communities. Now, if there are any bright spots to be found in the nation's response to COVID-19 pandemic, we see them in innovative endeavors like the food delivery boxes that were sparked by specific community needs. We also saw at a national level how some longstanding barriers to diabetes care could be waived during the public health emergency, making it easier for people with diabetes to continue using their preferred diabetes management tool or obtain new ones to help them manage their diabetes needs during shutdowns, extended quarantines, or hospitalizations. Now, what efforts are you seeing at the national level to reduce barriers to diabetes care and expand access to diabetes technologies?
That's a great question, Ed. My time on the National Clinical Care Commission, we really spent a lot of focus on diabetes technologies in particular. And we hope that any day now, and hopefully by the end of the year, our recommendations will be published. It just needs to be approved by Congress. And so many of our recommendations relate back to not only the technologies themselves, insulin pump and CGM, access to those technologies, improving access and removing barriers to telehealth, and also the traditional treatments and strategies that we see for both diabetes and diabetes prevention. We also spent a lot of our recommendations focused on that as well. So kind of the whole gamut, the whole approach to diabetes and prediabetes, and really even the upstream factors. We really spent our recommendations focused on all of those efforts in terms of removing barriers and improving and optimizing outcomes.
Well, one thing that we know for sure is that the problem is complex and the solutions are not simple. So clearly there are many contributing factors to diabetes disparities, but there are also a lot of stakeholders who are committing positive change. The Diabetes Leadership Council serves as a convener and a connector both within the diabetes community and beyond it. And we work with a number of other national diabetes organizations, as well as policymakers and staff, research organizations, academic, healthcare professionals, manufacturers, and systems stakeholders. We find that convening these parties helps us all to better understand complex issues, and while leveraging each other's strengths rather than duplicating efforts or missing opportunities. For example, this past year, DLC became the first patient advocacy member to the Diabetes Technology Access Coalition. Several national diabetes patient advocacy organizations, philanthropic organizations, device manufacturers, and leading clinicians have come together as DTAC to improve access to diabetes management tools. The coalition is focusing now on improving technology access and equity for Medicare beneficiaries by modernizing and simplifying coverage criteria. CMS has started taking steps in the right direction, but more changes are needed. And as you know, Medicare often sets the standards for other payers, correct?
Yes, absolutely. And early and sustained access to diabetes technology is now embodied in clinical guidelines from the American Diabetes Association, American Association of Clinical Endocrinologists, and the Endocrine Society. There's a rich body of evidence supporting access to these tools to help manage blood sugar levels or warn against dangerous highs and lows. These tools can help prevent complications for people with diabetes that people with diabetes experience on a day-to-day basis that can contribute to even costlier and sometimes devastating complications over time.
And finally, before we turn the mic back over to Bob in the Hill studio, we should address the cost of diabetes technologies. Can the nation afford to invest in broader and more equitable access to diabetes tech?
Absolutely. So between Medicare, Medicaid, the military, public payers cover 67% of the nation's diabetes costs. And unfortunately, 60% of overall diabetes spending treats complications rather than diabetes management or prevention. It would make much more sense from a clinical and public finance perspective to get the right tools in the hands of people who need them and then train them to use them effectively rather than paying for complications and disabilities in later years. Usually when I'm talking about what I do in a clinic setting, sometimes I say that I feel like I'm putting fires out, right? People are coming to clinic and A1Cs of 10 and there's such an opportunity to do so much more work earlier versus treating the complications. And so focusing our efforts more on the front end and preventing a lot of the damage that's done leading up to these complications is really where we stand to make a lot of improvement.
Yeah, it is also important to note for our audience that costs for diabetes technology and related supplies can be prohibitive for uninsured or underinsured people with diabetes. But help is available, whether it is at a community health center or through the states or manufacturers assistance programs. But viewers can find links to those resources on our website at diabetesleadership.org. So thank you for joining us today. I would like to thank Dexcom and Lilly Diabetes for making it possible for DLC to sponsor today's event. Their grant support helped underwrite the cost to sponsor this program, but the DLC worked exclusively with the Hill on its content. So now I'll turn it back over to Bob in the Hill studios.
Well, thank you, Edward and Jasmine. And now to further explore barriers to access for diabetes technology, I'm going to turn to my colleague, Julia Manchester. Julia? Take it away.
Thanks, Bob. I'm pleased to be joined now by a panel of distinguished experts. Dr. Ananta Adala is a pediatric endocrinologist and instructor at Stanford University. And Dr. Sanjoy Dutta is vice president of research at JDRF, a global organization funding type 1 diabetes research. And Dr. Gary Puckrin is president and CEO of the National Minority Quality Forum. Thank you all for joining me today.
It's our pleasure. Thanks for having us.
Thank you. So, Dr. Adala, I would love to start with you. Help our audience understand why these technologies that help people with diabetes navigate the disease, why they're so incredibly important to the quality of life.
That is actually the fundamental question, right? Before we can really talk about whether we should work towards coverage, is establishing that these are efficacious treatment. And I think that the data are overwhelming to the point, I think this has been said a little bit earlier as well, that international guidelines are very consistent that not only should diabetes technology be readily available to youth and individuals with type 1 diabetes, but also that we should consider expanding that. And it seems like the reason why diabetes technology is so helpful is because when you know your blood sugar numbers with as little effort, there's still effort. I cannot underscore that enough. There is an overall improvement in your ability to act on those numbers and your ability to prepare. And particularly type 1 diabetes is a sort of constant management. And this really offloads some of that burden. And then the other piece is that there are many data that are available that talk about the quality of life improvement, the fact that parents are getting more sleep than they used to. And so are adults who are living with type 1 diabetes. And this benefit extends outside of type 1 diabetes alone. And that's sort of one of the things that I think it would be important for us to start looking ahead, not only modifying our current coverage policies to simplify existing coverage, but also expanding it to other insulin-requiring diabetes is likely where we should be taking it because it is effective. It's been proven time and time and time again in small-scale studies, large-scale studies, diverse individuals. The evidence is overwhelming, and I think it's time we start acting.
Right. And on that note about expanding coverage, Dr. Dutta, I want to go to you. We know that technology has advanced over the years in treating people with diabetes, but unfortunately, as we've seen this technology improve and expand, there's been this disparity in who has access to that technology. Talk about how, there is this gap in access to these treatments.
Thank you. Thank you for inviting me. An excellent question from you, Julia. There is certainly an issue with access and affordability, especially in the lower socioeconomic strata and certain ethnic groups, subgroups there. And that is important to address. That is at the root cause of this. However, we will be missing the forest for the trees if we are only relying on access and affordability, which definitely need to be improved. And JDRF is doing significant work with the private and commercial payers, Medicare and others, to address that. There are additional issues that in our system, which is essentially broken and needs to be fixed here. And we can't attribute it entirely to access and affordability. For example, there's a significant lack of specialists providing diabetes care, endocrinologists, diabetologists, nurse practitioners, psychology specialists in diabetes. There's a significant lack there, especially in certain rural and ethnic communities and lower socioeconomic strata. There are, we know, cultural barriers. Some of them are historic and some of them are recent. Then there is a trust issue that is lacking, and that is something that can be built through a systemic change in the process here. There are significant medical care disparities in the US as well as outside the US. When you control for zip code, even the socioeconomic strata and all other variables, you still see a medical care disparity, medical care delivery disparity given to a white individual versus a Black American or a Hispanic American. And those are systemic changes that we need to do. And then finally, there's also a lack of people that look alike and talk alike that are delivering the care. And we need to do something to train the individual so that the future generation have a diversity even in medical care delivery experts and not just in looking at the patient population that needs to be taken care of.
Right. And Dr. Puckrin, how do we make sure that people, regardless of their race or zip code or socioeconomic status, how do we make sure they're getting this technology into their hands or into their doctor's hands?
I think we have to begin with asking ourselves the question, what is the purpose of our healthcare system? And the purpose of our healthcare system is actually to reduce risk. Reduce risk for all patients who come into the system, no matter their color, race, gender, age. And what we're doing right now is we've decided that we need to ration care, and we use things like ability to pay or race as a way to decide who gets access to what medications and devices. And at the end of the day, what that means is they end up with poor outcomes. Their life expectancy is shorter, the quality of life is impacted. And so we have to really start to reimagine. I think that's what you're hearing. We have to reimagine our healthcare system and focus it around managing patient risk. Too much of our system is focused on financial risk. And actually what we're doing is we're sacrificing the lives of many Americans.
And I'd like to toss to an audience question from Simye at home. They have a very interesting question on this topic.
Hi, my name is Samai Okyai, and I'm a health policy manager at Applied Policy. Applied Policy is a consulting firm located in Alexandria, Virginia. My question for you today is, why do we think there's such a gap in people of color accessing diabetes technology such as CGMs? What can we do to really understand disparities when it comes to life-saving technologies like insulin pumps? Thank you for your time today.
Dr. Adala, if you'd like to take a stab at that one first.
I would love to, because I think that is such an important question to understand and start wrapping our heads around. So I think the question was, why do these disparities exist and what can we do about it, right? And so the why these disparities exist is, I think that it's multifactorial, essentially, is what it comes down to. The system is not primed to support individuals who are racial ethnic minorities or are from low socioeconomic status. And oftentimes those two entities, being a minoritized individual and having low socioeconomic status, they co-occur, but they have their dual and kind of independent driver of adverse health. And what I mean by that is that simply because you are higher socioeconomic status, but if you're a minoritized individual, you have poor outcomes. There are plenty of data to support that, and vice versa. And so what I think is happening, and I think there's a body of literature to support this, is that there are multifactorial level drivers that result in inequitable care. So it's not on the community that's being marginalized or has been historically excluded. It's specifically on the system that set this up. And so that means it comes from the policy level. How are diabetes technology covered? Not only from the legislative standpoint, which is sort of the letter of the law, but the regulatory standpoint, how it's implemented. For example, in California, by county to county to county, there's variability in how CGM is covered for youth with type 1 diabetes. But the legislative piece is exactly the same. So there's that component. There's a level at the industry because you have to have the diabetes technology be approachable, right? It has to be in a number of languages. It has to be accessible in a way that makes sense to a diverse community. There's also inadvertently, I think providers end up playing a role in diabetes technology disparities, and there's some evidence to support that as well. I think it comes from being in the system that isn't really primed to support individuals who have been minoritized, who have been excluded, who come from low socioeconomic status, who have public insurance, specifically the population that we're trying to reach. And so I gave you a few very diverse and broad reasons why there's inequities. And that can feel a little overwhelming at times because it can seem like, well, the whole system's kind of worked against you. But what that also means is that there is multiple places where there's opportunities for each of these sectors to act, to modify, to pivot, and then move the needle towards disparity. And it really means it can be something that we all do in our day-to-day without sort of taking up the flag and saying, this is exclusively what I do. And so I think that is a wonderful question and what we should all be thinking about, what the next steps are, how we can change.
And Dr. Dutta, I don't work in the healthcare field, but I think for many of us following the news about the coronavirus pandemic and how it's impacted healthcare, it's really revealed and given us a closer look at the disparities that exist within the healthcare field and when it comes to healthcare access. I'm wondering if this had any impact on, access to people with diabetes have to that technology, to that treatment, and how the pandemic could have impacted the development of this technology. I'm not sure if I'm getting at something that's been covered widely, but I'm wondering if this has been a trend.
That's actually the very topical question for the last almost 20 months or 22 months. It's top of mind for all of us that work in the field of diabetes, type 1 diabetes, type 2 diabetes, and all forms of diabetes here. Some of these are the exacerbation is some of it is physiologic. For example, the coronavirus is what we call a pleiotropic virus. It affects many organs in the body. It particularly affects many of the metabolic organs in the body, like the kidney and the pancreas. And so as a result of which we have seen an increased incidence of diabetes, but we've also seen worse outcomes in people with diabetes. In fact, they are therefore categorized in a high-risk category for prioritization of the vaccines in the early part of the pandemic when the vaccines were not available. And there are other biological factors that have contributed to the disparity of it. For example, individuals with Black American individuals have some genetic predisposition to kidney disease, and those have been exacerbated during the pandemic. The non-physiologic factors that have certainly created a bigger, wider gap in disparity and access has simply been access to specialists, access to specialist care. You were not able to move out and about to go and see your doctor. Overnight, we had to transfer from an in-person patient-physician interaction to a virtual environment, and everybody didn't have access to it, particularly in the lower socioeconomic strata. Then there were also issues with job loss, rationing of insulin, rationing of food, and all of these things, and your lifestyle changes where your exercise, your movement, all of these things have totally compounded to lead to worse outcomes in people with diabetes. So what has happened is, unfortunately, that gap has only widened during the pandemic, and hopefully we'll be able to close it soon. And this has been an eye-opener for us as to what is inherently broken in the system, and we need to be working towards fixing it. As Dr. Adala said, there are opportunities here, and we should look at the opportunities and seize them as we recover from this pandemic.
And we're talking so much about the technology and the treatments, which is obviously so incredibly important to people with diabetes and the field of treating diabetes. But Dr. Puckrin, I would love to hear from you as to whether you think patients are getting the right education about diabetes, and if there's an awareness about the disease among people who could be at higher risk, or from people who don't know they're at high risk. Are they getting the right? Are they getting that information?
So in the National Minority Quality Forum, when we started looking at diabetes back in around 2000, somewhere around 3.5% of the American population had diabetes. Now it's over 9.5% of the population. We have an epidemic on our hands, and we're not addressing it. We're pretending like it'll go away. By 2030, we're talking about having about somewhere around 35 million people living with diabetes in the country. And we're not doing a great job in community. If you do a map and you look at where the diabetes educators, you're going to find that they're not in minority communities, that people are living with diabetes every day, but they're not getting the instruction and the way to manage their disease. We're doing a god-awful job managing diabetes in this country. It's one of the largest expenditures in the Medicare budget. Somewhere around 40% of all of the cost in the Medicare program is with an underlying condition of diabetes. People living with diabetes in the Medicare program, 60% of them are going to the emergency room or have a hospital event every year. That's an insane number. And it's all because we're not doing what we're supposed to do. And even more importantly, what we have the capacity to do. We can do better. We're just not doing better. It's systemic inertia, and we have to really bring this to an end. Otherwise, what we see with COVID, you're going to start to see by 2035 with diabetes, the healthcare system is not going to be able to manage what is going on in diabetes in this country.
And on that note, I'd like to go to another audience question from Sarah Brown. She's the Director of Government Affairs at Prevent Blindness.
Good afternoon. My name is Sarah Brown, and I am Director of Government Affairs with Prevent Blindness. Vision loss and blindness from diabetes-related eye disease is one of the leading causes of adult blindness in the United States. What is industry doing to ensure that technology is visually accessible to people who live with diabetes and diabetes-related vision loss and blindness, so as not to create an additional disparity in access to diabetes care for the blind and visually impaired?
Dr. Dutta, I would love to get your insight on that.
Yeah, thank you very much for the question from the audience there. GDF has a robust program in diabetic retinopathy here, and we've always had it. And I'm sure other organizations such as yours, where the question came from, is addressing it. Blindness due to diabetes is completely preventable. Is completely preventable. There is very meager genetic association with the disease. So they are mostly modifiable factors. So it's almost criminal to not be addressing it. There are modern technologies available for imaging the eye early on. They are affordable, they're scalable now. However, we need to have a systemic push to make sure that they are available at a primary care's office. And then that can be recommended to a retinal specialist or an ophthalmologist here. There are sophisticated tools available for early intervention in these diseases before you progress towards vision-threatening blindness, when options are few and far between. There is ongoing research right now when you progress around the pathway of losing your vision, as to get modern therapies such as regenerative medicine and other therapies to correct vision blindness, but that's not ready for prime time today. So there is a lot of opportunity here. The first thing we need to do is to educate the primary care practitioners to have screening tools. There are handheld devices that are, as I mentioned, affordable and scalable to be deployed at all of these clinics here, particularly in the adult clinics there. And then they can be referred back to a specialist clinic. So there are avenues there to protect using technology at this point in time.
It's really a topic we don't get to talk about enough, so I would like to thank all of our panelists again for joining me today. Dr. Ananta Adala, pediatric endocrinologist and director at Stanford Medicine, Dr. Sanjoy Dutta, vice president of research at JDRF, and Dr. Gary Puckrin, president and CEO of the National Minority Quality Forum. Thank you so much to all of you.
Thank you.
Thank you.
And earlier, my colleague Steve Clemens had a chance to speak with Congresswoman Diana DeGette from Colorado, who chairs the Diabetes Caucus and is a leading diabetes advocate on Capitol Hill. She also serves as chair of the Energy and Commerce Subcommittee on Oversight and Investigations. Let's take a listen.
Representative DeGette, thank you so much for joining us. As we've just been discussing, you and I have talked about diabetes before, what this country needs to do to make, just improve. This is a condition that is hitting so many Americans who need support and help. And I'm just interested, you have lived this experience. You're chair of the Diabetes Caucus. What is missing out there in terms of the planks of support that we really should be thinking about from a public policy perspective?
Well, as you know, and Steve, thank you so much for being with me again. It's a labor of love to do these talks. I think that we need to continue to double down on our efforts, both to find a cure for type 1 diabetes and also for type 2 diabetes, to find the appropriate treatments and prevention. Those are the two issues. And that means more targeted money in biomedical research. That means better drugs and devices and faster approval through the FDA and then through CMS, and really focusing in on trying to not just manage this disease, but really to try to cure it.
One of the areas of concern that I have looking at this is to look at the research dollars going into diabetes and what's going on in this arena. And when you compare this realm, say you were to basically put a sandbox around it and say and you compare it to other areas where we've made incredible advances, my concern is that when, are we doing what we really could be doing? Because this doesn't seem to be keeping up with the rest of science, the rest of biomedical research. Why has it fallen back in your view?
Well, obviously, we have the special diabetes program, which I spearheaded now. It's been almost 20 years, I think, since we first started doing it. And it has been a great influx of research dollars into the NIH. But yet, I think we just need to do more. One of the things I'm so excited about is I'm working with Congressman Fred Upton, who I worked with 5 years ago on the 21st Century Cures Act to target the way we do biomedical research, and then to find ways to approve drugs and devices. Now we are working on Cures 2.0 to help even more with a patient-centered approach, but we're also working to authorize this really big idea that President Biden had, which is to create an agency called ARPA-H. And ARPA-H is modeled on DARPA. And what it will do is it will be lean and mean. It will not have the same kind of constraints that our normal research agencies have. And it will be tasked with finding cures for diseases like diabetes, cancer, Alzheimer's, Parkinson's, things that we just haven't been able to get over the finish line. And we're excited about it. The administration put $2 billion in their budget this year for it. And so what Fred and I want to do is give the authorization to the agency. So we'll have a director, we'll have folks, and so it will work in collaboration and conjunction with the NIH, not to replace or to siphon off from the NIH.
And just so our audience follows, DARPA is the Defense Advanced Research Projects Agency. They're sort of the whiz kids of really novel, incredible, fast, out-of-the-box thinking in the defense side. And we've had a similar one in the Department of Energy called ARPA-E. And so ARPA-H, what I've discussed with Congressman Upton, would be, again, looking at these out-of-the-box, almost next-generation solutions. Do I have that about right?
That's exactly right. And I mean, DARPA, they invented the internet, and the concept is you bring people in, you give them a task, they think big, and then they come up with unconventional solutions. So it doesn't substitute for the basic research that we're doing, but it brings in some of the most creative and experienced minds, scientists, and helps them find these solutions. I think maybe that's some of the way we need to think about diabetes. I talked to some of the advocates and researchers, and people really have some very unusual and exciting ideas for how we could actually cure diabetes. And so I think that we need to really explore some of those as well as what we're doing.
Another part of this story that's kind of unfortunate right now, because it's also part of the COVID story. It's part of the fact that any disease, any chronic disease hits different communities in America unevenly. You have disproportionate share, depending on where you live, what zip code you're in, what race you may be. And when it comes to insulin pumps and glucose monitors, I'm just interested in what we need to think through so that people can afford what they need to deal with this challenge, and what we, not just the federal government, but what we in society, what levels that we ought to be thinking of different models of providing that kind of support for people who may not have easy access or be able to afford this healthcare, vital healthcare element.
Well, I mean, all of the technology is incredible these days. We've talked before, my daughter Francesca, she's 27 now. She was 4 when she was diagnosed. And she has so much equipment that if you asked me to do it, I probably would be at a loss these days, even though I was the main manager of her diabetes for many years.
Yeah.
And so everybody should be able to have, you're exactly right, everybody should be able to have that same access. What that means is that CMS needs to authorize the equipment, the pumps and everything else that goes along with it, and make sure that access to the highest quality healthcare for diabetics isn't just based on socioeconomics or on race. And so that's part of what actually, we have a whole section in our Cures 2.0 bill that Fred and I are doing to restructure CMS so it really moves more quickly to approve these things. Some of the issues that we've had around diabetes with CMS are just mind-boggling, where they'll approve one insulin pump but not another because of the way they are structured technologically. And I mean, it's just, and you know, the people at CMS, they recognize that. A lot of it is because of the way rules are written or statutes are written. So we're trying to clear up some of that bureaucracy.
No, I mean, you and Fred Upton, Congressman Upton, actually being a Republican congressman from Michigan, a Democratic congresswoman from Colorado, are doing so much on science. I mean, I just want to be, just tip my hat because you're doing so much on science in a bipartisan way. Does anybody tell you to stop playing across the aisle on this? I mean, do they say, hey, don't succeed, stop winning so much?
No, because you know what? Disease doesn't affect Democrats or Republicans or unaffiliated. It affects every family in America. And this is one reason why Fred and I really love working on this together, is because we feel that we get eager support, not just from our colleagues, but from patients and researchers and angel investors and advocacy groups. We get support from everybody, and people love that we are able to do something in a bipartisan way.
You tweeted out a week ago on October 18th, you wrote, nothing about Gail's insulin has changed, but its price has gone up by more than 600%. She's not alone. The skyrocketing price of insulin is affecting millions of Americans who need this life-sustaining drug. It's time for Congress to lower drug costs now. How is that going? You've laid it out very starkly, what's happening, what the person is feeling, what the person affected with diabetes is feeling in this process and these, large costs. And I'm just interested in how we're tackling that ecosystem if we are.
So the person I was referring to in that tweet is a constituent of mine named Gail DeVore, who's a wonderful activist. But this same thing happened to my daughter, Francesca. When she was 26, she was on my health insurance, and her insulin was $35 a bottle. And then when she turned 27, she went on her employer's health care, and she went in to get her prescription, and they said that'll be $350. For real, that happened to her. The same insulin, different insurance plan. And diabetics across the country are really facing this. Some of the pharmaceutical companies and manufacturers have been trying to find a way to make insulin available more cheaply, but it's not widely known and it's not widely utilized. And that's why I've continually been sponsoring bipartisan legislation on insulin pricing with the House Diabetes Caucus and the Senate Diabetes Caucus, to say that insulin can't go beyond $35 a vial. I mean, after all, if people don't take their insulin, they die. And so, it's sort of existential. And we held off for a while reintroducing our bill, our insulin price reduction bill, waiting to see what happened with HR 3, which is the drug pricing bill. And elements of that bill are included in the Build Back Better plan, but I don't know if it will survive into the final bill. And if not, we're really going to make a big push to pass this legislation. And I actually think insulin pricing can act as a model for other types of essential drugs. So if we don't pass it in the Build Back Better bill, you can expect to see our legislation.
Representative DeGette, just finally, one of the elements of this discussion, which we don't often, we recently did a forum on obesity, and obesity in many ways is tied to the diabetes challenge as well. And one other element that I just worry about with anyone that's living with a chronic disease and struggling to feel the cards stacked against them, whether they're type 1 or type 2, is what we as a society, your insights as a mom and as a person in society, maybe as a legislator, but more importantly, as a human being who cares about others. I mean, elements of stigma, elements of like how hard it is for folks to be dealing with this, that we ought to be thinking about as we discuss real people suffering with this challenge.
Well, so for people with type 1 diabetes, of course, as you know, it's an autoimmune disease. And so what happens is it's usually triggered by some kind of illness, and then your body loses the ability to make the to make the insulin. And so that's why you have to have it. And for those folks, there was a lot of stigma. And I think that we just need to take it out and not make it a secret anymore. Francesca, who's 27 years old, she wears her continuous glucose monitor right up there on her arm with her sleeveless blouses. And we've always raised her not to feel ashamed of having an autoimmune disease. With respect to type 2 diabetes, which can have obesity as a factor, again, I have relatives who have type 2 diabetes, and they were actually told by physicians, well, if you just lose some weight, you'll probably do better. And it's just sort of like, really? You think they didn't know that? And so I do think we have to start treating all of these diseases like diseases and think about working with patients in a patient-centered way about how we can solve them.
Well, Representative Diana DeGette from Colorado, chair of the Diabetes Caucus, I couldn't agree with you more. I really love your tweets. This one was so moving. You're paying tribute to, I think it's Lila Moss, who also walked the ramp wearing her insulin. And I just want to say thank you so much for what you're doing.
That's Kate Moss's daughter.
Wow. And so it's just great. It's very inspiring to read your tweets. So, I'm enjoying following you on everything, but thank you so much for joining us on this important topic.
Thanks for having me. This is really an important topic, and I'm looking forward to where we go from here.
Thank you, Steve and Congresswoman DeGette. Joining me now is Congressman Mike Kelly from Pennsylvania. He's vice chair of the Diabetes Caucus and a person with diabetes himself. He's also ranking member of the Ways and Means Subcommittee on Oversight. Welcome, Congressman Kelly.
Thank you. I'm good to be with you.
Well, as you know, Congressman, politics is personal, and diabetes is personal to you. You're a leader on the Diabetes Caucus. Explain how it is personal and why you've gotten involved in trying to come up with solutions to this big problem.
I think the main reason I'm involved with it, I'm a type 2 diabetic. I had absolutely no idea that I was a type 2 diabetic. I was just going through life as normal and, and just kind of going along. And my doctor said, I'm going to run some blood tests on you, which they do quite often. And he called me up. He said, listen, do you know you're a diabetic? I said, no, I didn't know I was a diabetic at all. How should I have known that? And he said, well, there's a number of things that could be there. And we went through them. I said, well, I think those are things that almost everybody goes through, doctor. I don't see anything unusual about that. But he said, well, you are a type 2 diabetic. And then when you look at the data and you realize that every year there's 7 million people, they have diabetes, but it goes it's undiagnosed. So there's a lot of people who don't know what they don't know. And one of those things is they don't know if they're a diabetic. They're looking at life and kind of going through life and experiencing different things. But I think most of the people that are like me is they get up in the morning and they get up to go to work, and they go to work in order to take care of their families, and they work all day and they come home and they enjoy being with their families at night. I don't think they really think, is there something wrong with me where I wouldn't be able to do this every day? So the fact that there's over 34 million Americans with diabetes is really alarming. And then it gets down to, so why are you that way? Is it that you don't know how to take care of yourself? You're not watching your diet, or is it something that's just part of who you are? It's just part of your background, and it was passed down to you through your genetics. But it's quite an unusual disease, in that it affects some. Type 1 diabetics really have a serious problem. They face a much greater consequences than a type 2 diabetic. Seems to me the type 2 diabetic can go along through life, notice little things that are wrong, be able to kind of navigate that, but not the same consequences as a type 1 diabetic, where that really does force you into a situation where your life has changed dramatically because of the seriousness of the diabetes. So I always thought it was genetic, something was passed on to you. And in my family, no, I'm the only one so far that anybody's come back and said, I'm a type 2 diabetic too. We'd have no type 1 diabetics in our family at all. So this is something that's a learning process, I think, for most Americans. Look at what you do every day and try to keep it in perspective of what do you see changing in your lifestyle. And then look at your own lifestyle. Are you a person that's aware of being taking care of your wellness? I mean, are you watching your diet? Are you learning more about your diet? Are you exercising? Are you doing the things that we learned as children growing up, and especially when you got to high school with phys ed and health class? They show you the food pyramid. They show you everything about what you should be doing. But I think, Bob, when you don't have something you're facing every day that changes your life, you kind of take it for granted. That's, hey, I'm fine and I'll be fine and I'm getting through life quite fine. But this is something that's very serious. And the main worry I think we all need to have are those who don't know that they don't know. And that's the big purpose of the caucus, to make sure we're getting that message out.
And that education is very important because, you see, as you said, day to day you can get by, but people with diabetes need to know they have diabetes so they can assess that and their physician, right? I mean, because in the long term, that's a real problem. It could lead to real problems.
Yeah, absolutely. Listen, again, we all have friends that have serious diabetic problems, which can lead, especially with the type 1. You got to be so careful as a type 1 diabetic. Most of my friends wear a device where the insulin is automatically injected into their system when the body recognizes that it says depletion. But the great thing, look, I mean, we can go back, I think, to the 20s or 30s, where 3 scientists at the University of Toronto actually discovered insulin. Now, this is going to be a shock to most people. They developed this and they sold the patent for insulin for $1 because they thought the value of this product was so important for mankind that nobody should profit from it. Unfortunately, not a lot of people feel that same way today, and we've been through a lot of different efforts. We wanted to get a generic substitute for insulin. We found out we just ran out of time on it, and the reason we couldn't get to it, my understanding from talking with the people in the administration, the previous administration, was, Mr. Kelly, you have no idea of how many lawsuits we would be in and how many years we would be tied up in court and how difficult that would be. What we're working on right now is a biosimilar, which is a product that's similar to insulin. We were looking for the generic substitute because it's the exact same thing as the regular insulin. We were looking for that, but where we are today is biosimilars are being developed, and we're trying to get to a point where that price of controlling your diabetes is affordable.
And that's one of the biggest problems, because you have, there's disparities and health disparities and across the board, whatever disease it might be. But as far as getting the necessary treatment and the technology, is that one of the biggest problems here with people with diabetes?
But I think there's a number of problems. I think the main problem, I think, is the fact that there's too many people who are uneducated when it comes to what should I be looking for in my life that would give me an early warning sign that I can start to adjust and actually learn to live with this. That's why I said earlier, again, I grew up in a world where we had gym class and we had health class. The differences between the two is gym class was actually physical activity where you went out and you did something every day and you learned how to do different things. And even as you age, you were able to participate and keep yourself in good shape physically. The health class was more about learning how to build the food pyramid, understanding that what you put into your body has a dramatic effect on how your body is going to age as you get older and what you're going to be able to fight off your immunities and not be compromised. So I think a lot of this is the fact that you cannot be a sedentary person and expect that you're going to have a long, active life. You have to get up, you have to get moving. In a lot of cases, you get older, just get out and walk every day, do the things that we normally would do. Do those type of things, and then watch what you put into your body. Nutrition is an incredibly important thing, and a lot of it comes down to, please, if you want to live a long and productive life, take care of yourself. I'm an automobile dealer, and one of the things we talk about all the time when people get a new car, look, watch the alignment or your tires will wear out. Watch the tire pressure or your tires will wear out. Make sure you're changing the oil. Make sure you're taking a look at the transmission fluid. Why do we want you to do that? So that you'll get a longer term out of that vehicle as it goes forward. And when you do things like that, when you do this preventative maintenance, it's the same thing with us. It's the same thing with us. We are a machine. Whether we want to admit it or not, we're machines. The better care you take of your own body, the more likely you are to live a long and productive life and a happy life. A lot of it comes down to wellness. A lot of it comes down to nutrition. But that really comes down to how much do you care about your own health to actually take a look into it. This diabetes is a difficult and a horrible, horrible disease, but it can be managed.
And all of what you said as the last question is even more important during a pandemic because COVID-19 is more deadly if you have diabetes, correct?
Absolutely. Absolutely. I think people have to understand that you have to be able to fight off whatever it is that comes at you. And the better shape you're in, the better health that you're in, the more likely you are to stay healthy and be able to fight off any of these different diseases that are rising. We're seeing all the variants with COVID. It seems like every day we find something new about it and something we didn't know the day before. But again, it comes down to, are you able on your own to fight off this disease? And a lot of it comes down to, is what we're talking about, Bob, is knowing from a wellness standpoint, how do I stay healthy? A lot of it is what you eat. A lot of it is getting out and exercising. But more than anything else, get informed and find out so you know ahead of time. There's nothing. And early detection means you're going to have a better connection and a better correction.
Our thanks to Congressman Mike Kelly of Pennsylvania, Vice Chair of the Diabetes Caucus. And now my final guest is Grammy Award-winning music legend Patti LaBelle. She was first diagnosed with type 2 diabetes over 20 years ago and has since become a diabetes patient advocate. She is also a spokesperson for Dexcom, which is supporting Diabetes Leadership Council's sponsorship of today's program. Welcome, Patti. It's an honor to interview you.
Thank you. I'm happy to be here. Thank you.
Now, as I said, you were diagnosed with type 2 diabetes in 1995, and since then, you've said some of your best friends are your doctors. Can you talk about how important the doctor-patient relationship is in managing diabetes?
I had an incident on stage 26 years ago. I passed out, and I thought that it was exhaustion because we were touring a lot. And they rushed me to the hospital, and the doctor came out and said, "You're a type 2 diabetic." So right then I got really, I was scared because my mother had amputations. My aunt lost her eyesight, and so many of my family members dealt with diabetes, but they didn't have the provisions that I have today to make my diabetes livable. And so my doctors, I see my doctors every single month. I have about 5 or 6 doctors, not all for diabetes, endocrinologists, but I have all types of doctors because I was afraid to go to doctors. Before I passed out, I had never gone to a doctor. So I could have found out that way. And I do believe that most people are afraid of doctors' information, that it could be negative and they can't deal with it. I say, go to your doctor because my doctor is my best friend, all of my doctors' best friend.
Well, that's pretty good. Well, Patti, tell me about what you've learned about the healthcare system and ways that you think it could be really improved for people with diabetes.
Well, the underserved communities are really in trouble. I do believe that we need more awareness. It's like we sometimes have town meetings for school districts, school meetings and different things. I think if we had a town meeting for diabetics, they could learn much more about it, how if they have Medicaid or Medicare, or check with their insurance to see if they're available for them to have like this device. And access to resources is so important. And by joining the town meeting or something like that, they can get great information. So I think it's necessary for us to do things like that.
And have you seen some improvement? And obviously, it seems like we've got a long way to go as far as disparities in access and diabetes technologies like insulin pumps and continuous glucose monitors. that if you're better well off, then you've got a better chance to get better care. How can policymakers kind of fix this issue, in your opinion?
In my opinion, is like I said, town hall meetings, some kind of information center for diabetics to go to and get information that they wouldn't normally get because they're afraid of going to doctors. And I believe that with my having now access to my device, I've turned to a lot of my friends, my hairstylist. Her mother's a diabetic, and now she has a Dexcom. So I'm always spreading this great information about this device. Mm-hmm. And I guess if we just pay more attention to people who are diabetics. I'm kind of nervous today, Bob.
That's okay. I'm a little nervous interviewing you, so I understand. But your experience. So in your experience, it's really education, right? You're spreading the word, whether it's through the airwaves, but whether it's politicians or anybody else, because a lot of people who have diabetes, they don't even know it, right?
I didn't know it. Of course, there's so many people like me who never went to a doctor for anything. And so therefore, I had no clue that I wasn't losing my family members to diabetes. I was so happy that I fell on that stage and got information from a doctor. You're a diabetic. Mm-hmm. Mm-hmm.
Yeah, and
so
lastly,
it's a silent disease, dear.
Yes, no, it is. It really is, and I think you're spreading the word is a valuable thing in getting people to know and trust their doctors. That's the most important thing I think I've learned from you today. And thank you so much for joining us.
Oh, my pleasure. Thank you.
Thanks again, Patti LaBelle, Grammy Award-winning artist and diabetes patient advocate. We're glad you could be with us today. Well, that brings us to the end of our program. A big thank you to the Diabetes Leadership Council for its support and to all of you attendees for joining us for this important discussion. Thanks also to Julia Manchester for joining me in studio. And for those who missed any of these conversations, we will have video from the event shortly on our website, thehill.com. I'm Bob Cusack. Be well.